Thank you, Professor Ines. It's a great pleasure for me to be with you and to participate to this important meeting. Professor Andrew is now. He is the professor of medicine in Manchester. He is president of IDF, former president of AASD. He lives between Manchester and Miami, and he's a very important person and probably is one of the famous diabetologist and expert in food in diabetic foods. It's a great pleasure to give you the floor, Professor Andrew, and many thanks for your help for MENA region, for physician in our region.
Well, merci bien, shukran to my good friend Jamal, and it's good to see you, even though we can't be together in person. And you said that I travel between Manchester and Miami. Very sadly, that's not been possible for a long time because of the situation we're in now, but there we are. So I'm going to talk about COVID-19 and diabetes. Oh, that's interesting. My slides went forward now. Ah, there we go. I won't try and steal Akhtar's thunder, but just one or two slides on the problem we're facing with this global epidemic of diabetes before I talk about the global epidemic of COVID. Huge numbers across the world, especially in your region. And here is a study from our good friend Abdul Basit, the former chair of MENA, and he showed, of course, the population of Pakistan, adult population, more than 1 in 4 has diabetes. A study here from Egypt, it's actually higher now, probably about 16-17%, but this was a study published in 2015 from your country of Egypt. So we have what Ronald Marr described as a rising global health tsunami, which is a huge problem. And now we have this extra problem thrown upon us as well. So let me just ask you this question first. Could we say that diabetes is the cancer of the 21st century? There are similarities. We know that screening of high-risk groups is effective for cancer. We know that long-term remission and even cures are possible. That's true also of diabetes now. The increased public awareness has been very effective in bringing people forward to be screened, and also in bringing money forward for research. Now, I don't want to propose that we should use fear arousal, but there's no doubt that people are frightened of cancer because they think it kills you. Whereas some people say that diabetes is not really a major problem, which is sad. We need to raise the profile of diabetes, especially at these very challenging times when diabetes is being pushed aside by this horrendous global pandemic that nobody could have envisaged coming upon us just a year ago. Here is a patient with diabetes, someone with diabetes, writing last year in the Sunday Times of England. He wrote this: "Cancer is serious. Heart disease is serious, but I never thought that diabetes was serious at all. It didn't feel serious. And now I've only got one leg." So this reminds us that, like in many forms of cancer, early on diabetes can be silent. Early on diabetes complications can be silent. So we need to move back and screen much earlier for those people who are at high risk, and also regular screening for complications, which can all be silent until it is too late. So let's move on now to the topic of diabetes and COVID-19. This paper published just a few months ago in Diabetes Care from the early reports from Wuhan. And the good news here is that there were few reported cases of hospitalized patients aged under 35 with diabetes in not only Wuhan, but also in Italy. In Wuhan, in the early days, the beginning of this year, around 1 in 10 of hospitalized patients had diabetes. They were older, but they had higher mortality. And adverse outcomes were related not only to older age, but complications and poorer blood sugar control and obesity. So here are some questions in a very nice, and I would commend this to you. This is a nice review, a commentary in Diabetes Care just a couple of months ago, which you can get free of charge, by Liz Selvin, who's a well-known epidemiologist from Johns Hopkins University in Baltimore. And she asked some questions about diabetes and COVID-19. First, is diabetes a risk factor for COVID-19? Well, we know that certain infections are more common in people with diabetes, but there is actually no strong evidence to support that diabetes itself is a risk factor for COVID-19 infection. And it may be the inequities in healthcare, poverty, poor housing, ethnicity, etc., might perceive to this perception that people with diabetes are at greater risk. Question 2, does diabetes independently contribute to poorer outcomes in hospital? Well, we know that diabetes patients are older and they're more likely to have comorbidities that I've just described. There is no definite evidence that diabetes itself independently leads to poorer outcomes if you look at studies together, but some individual studies from different countries do suggest that this might be the case. In most cases, it may be that obesity, hypertension, cardiovascular and renal complications may be driving the worse outcome. The third question is, what is the role of obesity? There is evidence that obesity is an important risk factor for progression and death. This may relate to obesity affecting ventilation with reduced residual lung capacity, or maybe obesity can play a major direct role, perhaps via inflammatory pathways or biologic effects on, for one example, epicardial adipose tissue. Here is one study from England, from my country, and this is a population-based cohort study of people registered in primary care in the UK. We have a large primary care healthcare registry, so we can do this kind of study. Among 61 million people on this database, 5%, 1 in 20, had diabetes. Of 23,800 COVID-related deaths until 11th of May, 1 in 3 occurred in those with diabetes. 31% in type 2 diabetes, 1.5 in type 1. Crude mortality rates, of course, higher. And even if adjusted for age, sex, ethnicity, deprivation, location, the odds of dying are higher in people with diabetes compared with those without. If you further adjust for other comorbidities that I've already mentioned, still higher. So in this one study, diabetes was independently associated with an increased risk of in-hospital death. But if you look across multiple studies, this may not be entirely the case. What about the United States? They're also experiencing an increase in cases, with over 80,000 cases one day recently. Here's a retrospective electronic medical record chart review of 6 weeks, March, April. In Columbia, the well-known hospital and medical school in the Upper West Side of Manhattan. 850 admitted, 236 ICU. Diabetes, obesity, and hypertension were common, especially in those with ICU admissions. So adverse outcomes were related to ICU admissions and the other comorbidities. So again, diabetes. Then we've had some interesting real world, if you like, studies that have been put forward before they've been peer reviewed. And we know because of the trial of dexamethasone in severely ill ICU patients treated in the UK, its potential was used in managing the cytokine storm in people who were very sick on intensive care unit. It appears that the current United States president read about this, and even though he wasn't advanced, he seemed to take dexamethasone and anything else that was going. So I don't know if that actually helped him or not. We'll never know. And it was interesting to hear our Prime Minister saying, oh, we need to know something about this drug dexamethasone. When's it going to be available? He didn't seem to realize we've had this drug for years. But this is an example of a study that actually showed benefit. And here are the results. of 2,100 patients receiving dexamethasone compared with double on standard of care, the death rates were reduced from 40 to 28% on those on ventilators, and even those on oxygens were reduced. So the number needed to treat is not that high to save one life. So the cost is low. So we have an effective treatment for severely ill people, and it may be that's why, together with other treatments, that we're seeing fewer deaths on ICU than we saw in the first wave. Another question is ethnicity. What about ethnicity in COVID-19? Another study from the UK, again, it was released before it's actually been published. This is a study of patients admitted between February and May to 60 United Kingdom hospitals. 35,000 patients enrolled, so it's a good number. Those in the ethnic minorities were younger with more diabetes, and higher adjusted mortality was seen in all ethnic minorities, especially in excess in South Asians, was mediated by pre-existing diabetes. So we need to consider this and these results in policy planning as to who should be looking after, for example, some of our best nurses in the hospital, for example, come from South India. So should we be trying to protect people such as them who are seen to be at greater risk? Again, here's a review from my good friend Matt Riddle, the editor of Diabetes Care, and in fact all the editors will be putting out another commentary in January talking about all these problems with COVID. This is a review of lessons to be learned to those with diabetes from all the published reports, again, just published. And this suggests that diabetes, again, was not shown to increase the likelihood of doing poorly, or getting an infection rather. It did introduce problems for those who had diabetes, and they did do worse, that's for sure. So progression to more severe disease is likely. Diabetes is 2 to 3 times more common on ICU admissions. So diabetes, obesity, ethnicity, and late complications, additional additive factors. So we need to continue support for vulnerable people. So what has been the effect of COVID-19 on non-communicable diseases? This is a very important question for those of us in diabetes. The pandemic has undoubtedly led to a neglect of many conditions. This review in the British Medical Journal by the editor emphasized cancer, heart disease, did not mention diabetes. Yet again, we need to fight for diabetes to be included here. The BMA has emphasized the need to tackle the backlog of non-COVID treatments. Positive improvements have been seen. Because of COVID, there's been reduced bureaucracy. Things are moving faster. We're learning new ways of consulting patients, but these need to be maintained. Here are lessons for diabetes, and a piece by Partha Carr in the British Medical Journal. 1/3 of COVID deaths, that I also say, in diabetes, age, overall poorer glycemic control, other comorbidities predicting poor outcomes. We need a parity of focus on all types of diabetes. And of course, we need to remember we're seeing diabetes developing during COVID for many reasons. Maybe the stress of infection, maybe a specific condition, the use of drugs such as dexamethasone, etc. So diabetes is a huge load now in inpatient care, and it needs the attention it deserves. So let's look at threats and opportunities. There are threats, especially early on during this pandemic, and it may come back now with a huge second wave. The threats are people are shielding, they're staying at home. This may lead to poorer diets. Even our students in Manchester, of course, when they came back to university, we had a huge increase in COVID positive testing, and they were all shielding in halls of residence. Even the students complained about the diet they were sent in. High in fat, high in highly refined carbohydrate. So this is a threat, poor diet, lack of exercise. Patients are not going out. Poor glycemic control, and the psychological impact is one contributory factor to poorer blood sugar control. Fear of hospitals. Of course, people with diabetes know that they're at greater risk, and they don't want to come to a hospital clinic. They know that the hospitals are where people with COVID seriously ill are. To counter that, I moved most of my complications clinic to a community health center. And at my diabetic foot clinic last Friday, and I'll be there again tomorrow, I saw 39 patients in the morning, 100% attendance, whereas in the diabetes center in the hospital, 50% attendance. And what my fear is, because of all these factors, we're going to have a tsunami of late complications as a consequence of this long-term problem affecting our people with diabetes. But there are also opportunities. The expansion of telemedicine, digital education programs are now available online, such as Desmond. As I've mentioned, there's been forced upon us, like Malvolio in Twelfth Night had greatness thrust upon him. We've had the need to improve inpatient diabetes services because half the hospital nearly has diabetes because of all these COVID patients. Enforced diabetes service redesigns, that could be very helpful. The threats of cancellation of all routine clinics. From March, all our diabetic clinics were being cancelled, stopped. Access to medications and supply chains at IDF, we've been watching this across the world. We've not been able to do routine investigations, even an X-ray, blood test. During the lockdown between March and May, it was all done on good clinical practice, taking a history and examining the patient. Suspension of all non-emergent surgery and transplant surgery. The best treatment for diabetic nephropathy, of course, is to prevent it. The second best treatment in end-stage renal disease is a transplant. We're just starting up again now, but that will probably fall off again because of the second wave. Lastly, I'll just say one or two things about my own area. If you look at those on the left who do badly with COVID, they're older, male, obese, poor glycemic control, hypertension, heart disease. These are the very same population at risk of diabetic foot disease, as you see on the right. So the threats to neuropathy and vascular disease, again, the suspension of all routine lab tests. I mean, junior doctors come to me today and said, oh, what's the CRP? I said, well, I actually treat the patient's osteomyelitis. Looking at it, I don't treat the CRP. But this has been taken away from them, the chance to check all these tests, a routine X-ray, MRI, non-invasive laboratory tests. I have a handheld Doppler, very helpful to listen and learn. So we just published a paper in the September edition, I think, of Diabetes Care, Saving the Diabetic Foot, A Tale of Two Cities. Los Angeles and Manchester. Los Angeles, my former PhD student. David Armstrong is professor of surgery. So we compared the changes, and I'm not going to go through this because many of you have heard me say this before. But basically, in Manchester, the top two columns, we continue clinic visits, but lower, some telecare, podiatrist visits with patients at home, but we markedly reduce hospitalization. In Los Angeles, they did a lot of telecare. They don't do any home visits in the US, but they had fewer hospitalizations and fewer clinic visits. One case report, and I'll stop. This is a 73-year-old man of Indian subcontinent origin with neuropathy, heart disease. He presented just before lockdown with an extensive ulcer on his medial interphalangeal joint right hallux. And you can see this here. And you can probe into here, into the interphalangeal joint space here. You can probe to bone, that's osteomyelitis. We did get an X-ray the week before, and he had extensive osteomyelitis, as you see here, and a septic arthritis in the interphalangeal joint and destruction here and here. So extensive involvement. Before that could have been either intravenous antibiotics or taking the toe off or a first ray excision. I elected to treat him with broad spectrum antibiotics for 8 weeks of this combination, clindamycin and ciprofloxacin, without the ability to do any further tests, and it healed up. And we have been able to do a subsequent X-ray that showed radiological healing. So there is evidence to support what we're doing, by the way. There's a trial just published last year in the New England Journal that shows that for osteomyelitis, intravenous antibiotics confer no benefit over oral. So we had a reason to do that. So I would leave you with a few thoughts. Dominic Corrigan, the great Irish physician, whose bust is in the Royal College of Physicians and Surgeons in Dublin, he wrote these words: the trouble with most doctors is not that they don't know enough, but they don't see enough. Throughout this pandemic, it's clinical practice that has mattered most, history and examination, good clinical medicine. such as this we described in 1983. Distended dorsal foot veins as a good sign of autonomic neuropathy due to arteriovenous shunting, increased arterial inflow, and you get these distended dorsal foot veins. You don't need any tests to look at that. So the threats, as I've said, and the opportunities are here too, and this includes good clinical practice for looking after the diabetic foot. But I would suggest to you that the major threats are here. We have a double whammy. Not only is clinical research swinging back to infectious disease, but also we've got a loss of income for major diabetes associations. Of course, having the ADA and the AASD virtual has been a big financial knock. And I can tell you that after the AASD, there was a poll amongst people who attended, and around a vast majority of people said, we can't wait to get back to proper face-to-face meetings where we can exchange ideas, network, discuss research over coffee break and so on. But the second problem is that clinical diabetes care is suffering, as I've shown you, and this fear of hospital clinics is leading to poor clinic attendance. So we have huge challenges as hopefully next year we come out of this pandemic with, as they say in America, a vaccine soon going to be available. So threats and potential solutions, we need collaboration between stakeholders with major interest in non-communicable diseases, which we've done at IDF. We're working closely together with Non-Communicable Diseases Association, the Global Coalition for Circularity Health, the World Health Organization, and so on. We need to increase global awareness of diabetes as a serious, potentially life-threatening with late complications condition, and a message to politicians, read the epidemic and the costs of diabetes. Remember that in some developing countries, up to 40% of healthcare expenditure goes on diabetes. But a little bit of expenditure now with screening for those who are at high-risk groups and screening those who have early diabetes to try and prevent the complications will pay dividends in the long term. So what I'm proposing is a global call for action and of increased awareness of diabetes as a potentially preventable disorder. So I'll leave you with a couple of quotes. Wilson wrote this: "You teach me and I forget. You show me and I remember. You involve me and I understand." Let's involve our patients, our people with diabetes, and help them to understand the risks and how much they can do to prevent these problems. But also, let's involve our politicians so that they realize the huge costs of diabetes and the social costs, the individual costs, etc. So Enrico Fermi wrote these words, and I hope it does not apply to you. Before I listened to your lecture, I was confused. Having heard it, I'm still confused, but at least at a higher level. So, shukran.